So we're going back to the order with the RFA for Genomic Medicine eConsult service. And this is Renee Ryder, Program Director in Genomic Medicine. We'll present the concept.
This up, I just wanted to thank everyone who actually had input on this concept. We had input to help mold and develop this concept from every division in HGRI. So you can really see what great minds helped, I think, develop this concept from all over. Okay, thank you. I'm really excited to be presenting this concept today that is on the research on the impact of and methods for implementing regional genomic medicine eConsult services. Before we begin, I'd like to introduce a definition of what I mean when I'm talking about eConsult services. eConsult services are clinician-to-clinician support that do not directly involve the patients. You can see in the diagram here that a primary care physician requests the concept, sends the relevant patient information to the specialist reviews it, and then sends back a response. The patient's not involved in that. eConsults have been shown to be very beneficial in many different specialties. They've been shown to provide actionable recommendations to the primary care physicians. They increase the primary care provider's ability to provide care and decreasing the need for specialty referrals. They reduce wait times, they decrease patient burden, and most importantly, I think they increase health equity. Most of the eConsult services are within single institutions, and right now there are very few genomic medicine eConsult services. This concept is specifically about regional eConsult services, and what we're talking about when we say regional consult services are multi-institution eConsult services, where specialists at one institution provide support to clinicians at many other institutions, including those outside of their system. Looking at this diagram here, you can see that perhaps an academic medical center has an eConsult service, and they're providing services to the solo provider down the street, or maybe the safety net system, or maybe the other academic institution that they're in competition with. What this does is it allows clinicians without specialists at their institution to get patient-specific recommendations on genomic medicine questions. And these have been shown to increase health equity in groups such as the frail elderly, long-term care residents, rural patients, and in transgender medicine patients. We did a literature review, and I think that you can really divide the literature that we found in two different ways. First is the specialty of the literature. There were some that were focused on eConsults that were not genomic medicine, and then there were some focused on genomic medicine eConsults. Then the reach. There were some that were only within a single institution, and then there were a few papers that were on multi-institution or regional services. When we looked at the single institution, not genomic medicine services, that's where the bulk of the research is. And the research shows that these are feasible and they improve patient care. When we looked at the landscape analysis, there are many health systems that are doing these types of consults, and there are already modules built into large EHR systems in order to get those consults in and out. However, when we look at genomic medicine, we only found one publication inside the United States. However, when we did a landscape analysis, we saw that there are 5 established services, one that's only doing pharmacogenomic consults, and there are 2 services that are currently being built. Then when we look at the regional eConsult services, again, not genomic medicine, again, the literature shows that they're feasible and they improve patient care. When we looked at a landscape analysis, we found that there's currently a corporate grant to the federally qualified health centers to provide eConsult, specialty eConsults. There's also a transgender medicine eConsult services. There's pediatric mental health. There's HRSA has funded an HIV/AIDS care consult services, and there are many others. However, when we go to genomic medicine, we only found one publication, and that's from Canada. When we did a landscape analysis, San Francisco currently has a safety net eConsult service. The only genomic medicine that they include in their service is cancer genetics only. The New England Regional Genetics Network tried to implement a a genomic medicine eConsult service, but they ran into too many barriers. And those barriers included lack of physicians that actually had licenses, to a lack of people actually able to do those consults just because there weren't enough consults. What this really led us to understand is that there is a knowledge gap, and that knowledge gap is twofold. First, we don't understand the impact of genomic medicine eConsult services when they're implemented on a regional scale. And the second one is that we need to identify and overcome barriers in implementing regional genomic medicine eConsult services. A lot of people, when they think about implementation science, they only think of implementation science that's for things that are already established as evidence-based practices. However, there are hybrid designs out there for continuing to accumulate evidence at larger scales while studying how to best implement. And we think that that's the type of implementation science that would be best suited towards answering the questions that this consult proposes. And those research questions, we have 3 research questions in this consult. The first is, what impact do genetic eConsult services have when they're implemented at a regional level? The second is, how can regional genomic medicine eConsult services be implemented and sustained? And then the third, can tools be created and shared with others who are creating regional eConsult services? So our proposal is to create an RFA to implement, evaluate, and refine regional clinician-to-clinician genomic medicine eConsult services. We would like to fund 2 to 3 U01 awards, which for those of you who don't know, those are the cooperative agreements. Each site would test separate projects that would be looking at their own diverse service models that would address their own local barriers. But yet they'd still come together for collaborative meetings that would be all the sites and program office. During the first 6 to 12 months while they're starting their services, we would expect those to be monthly, and then thereafter quarterly. The objectives of the collaboration would be to establish common metrics, discuss obstacles, brainstorm and share solutions, review the stakeholder input. We did want to have each site have an advisory board, and to discuss progress and timeline. The scope of the service, I get questions about this. How big of a service would people need to propose? And what we would like is that they propose a geographic region or a non-contiguous selection of facilities like federally qualified health centers or the Indian Health Service locations that's large enough to expect about 1,000 consults a year. And that service would have to, that scope would have to include a variety of settings such as academic medical centers, community hospitals, private practices, safety net services, ideally using multiple EHR platforms so that we could really see how this could work in a wide way. And they would also need to include at least 2 medically underserved populations or areas as defined by HRSA, and ideally they'd serve multiple states with different licensure laws. Each site would have some activities that they would be required to do. As I said, they would each test their own distinct service models, and they'd each have 3 operational goals. The first is they'd have to set up the eConsult service. Second, they would conduct outreach, promotion, and education on their eConsult service to get people to send in consults. And then finally, they'd have to provide those each consults. In each of those goals, they would need to assess both impact questions and outcomes and implementation questions and outcomes. They'd also need to create implementation tools that they could create and then disseminate to other services. For examples, I think it's really good to just give you a couple of examples. I'm not going to read all of these, but when we're talking about impact questions, we're talking about questions like, do genomic medicine eConsult services improve health equity and access? For the outcomes that they could measure things like the number of eConsults that recommend medical management changes, and also the number of eConsults that actually result in changing medical management. When we're looking at implementation questions and outcomes, we're looking at questions like, what are the best methods for receiving eConsults requests? And then what are the best methods for triaging those eConsults? Again, they could measure a wide variety of outcomes like the number of requests that are received by different types of providers like nurse practitioners versus physicians, or from different facilities to make sure that they're getting that wide range that, that they've done outreach at. Next, there are lots of different implementation tools that they could create. Two examples are the forms that they create when they're receiving eConsults. They could create those as an implementation tool, or maybe a triage algorithm so that when other people are creating them, they already have an idea of if it's this type of question, we should triage it to an oncologist, or if it's this type of question, maybe a genetic counselor could handle that one. As far as funding goes, we propose, NHGRI proposes to fund 2 sites for a total of $16.7 million. As you can see, in year 1, it would be about $3 million going up to $3.5 million in year 5. That's because we do expect the number of consults to grow over time. That funding, we would also request co-funding from other institutes and federal agencies. If we get co-funding, then we would use that to increase the number of sites, the scope of the project, or the speed of the expansion, or the evaluation of the service. And now I'd like to open it up for discussion. We have asked Dr. Jarvik and Dr. Kulo to start off the conversation.
So thanks. I think this is a really important gap in our healthcare system. We have these pools of expertise in academic centers, and you have to come to us to get that expertise a lot. I understand it's peer-to-peer, clinician to clinician, but there are still licensing implications. Do you expect the providing hospital or center to have licensed physicians in the region that they're serving, and would they also need access to medical records at institutions outside of their own?
So we have looked into some of the licensure issues, and that really depends on where you are in the United States. That was one of the problems that the New England Regional Network faced, was because that happens to be a place where every state requires a license in their state. We also talked to someone in Texas who said, yeah, we don't really care about that. It's Texas. So, it's going to really, I think this is why it's really important for us to try out many different models to see what will work in different locations, and then to pool that information. As far as those states like the New England, I think that this is, again, why we're choosing an implementation framework for this concept, because I think there are lots of different solutions. If we look at what's being done, Color, for example, has genetic counselors practicing across the United States, and they have methods for figuring out where those genetic counselors are licensed and where they can provide services. So I think there are lots of models that applicants could look to solve some of those issues.
And then as you think about sustainability, right? Because so one thing that we learned in the UDN is when you have a very valuable service and you try and take it away, people get really crabby and want you to keep giving it to them. And so especially because you're addressing underserved populations here, that's a real concern that I have of how you build a sustainable model, because there isn't reimbursement for peer-to-peer conversations for the most part, and certainly not outside of your institution. So have you thought about how you would start immediately working towards sustainability, and what possible partners toward that there would be?
I think, again, that there are lots of different avenues that they can research, and that for this concept is, I think, a large focus of the concept, is that from day one they need to look at and propose methods to research for sustainability. What feedback we've heard is that there are some methods that can be used for billing, that HRSA's, I think it's their pediatric mental health model, they've actually found out ways to have not the consultant bill, but the consultee can bill for their time. So we can, there are ways to do it on that side. There are some reimbursement mechanisms on the consultant side. I don't know that those are going to be enough to cover it, but I also think there are other models that we've heard talked about, like some places apparently can credit some of this work towards what they're donating to charitable care. One of the people we talked to said that their hospital saw cost reductions in downstream services so that they were able to kind of justify it that way. We also hope that through the gathering of this information over 5 years, this could be data that is used to justify higher or more or less reimbursement from the payers. So we think of this as both data generating and finding out the solutions that currently work.
Thank you.
That was the long answer, I'm sorry.
No, it's a really important answer.
Iftikhar.
This is a great idea, and you did a really nice job in reviewing the literature. Thank you for that. I think it'll help with access and equity, which is really at the forefront. I think the sustainability is the most important issue. You covered it. Logistics, 1,000 a year means 5 a day. That's a lot. Mm-hmm. That's a lot of so would there be like hotline or teleconsults that you don't always have to do e-consults?
I kind of hear two questions there. One is about the volume.
Yeah.
As far as the volume goes, we did specifically select a larger volume because some of the feedback that we got is that when you have a lower volume, it's hard to keep the consultants engaged. Once you learn how to use the system, if you don't do the consult for a month, you forget how to use the system. And also, when we were looking into the data over what types of genomic medicine e-consults are received, it's 5 per day, but that's going to be divided out amongst the oncology, the nephrology, so it's going to be lower volume for each of those. Then your second question was about what type, how you can respond to e-consults, and we really want to leave that open. We've seen some successful models. The HIV/AIDS consult service is actually done by mostly a telephone hotline. They also have a web portal, but they find that the telephone hotline is where they get most of it. We've seen some that do like a Zoom call between the providers, especially if they need to share images or something. At the VA, they do I think they call it store and forward, where you can take images that get forwarded. So we're leaving it open for how it's done, but this is specifically for clinician to clinician, not for patient referrals.
And the second comment is there's a lot of room for innovation here. So one, if they don't, having a common EHR would be really great. It makes the ordering, the billing, the documentation so much easier. But if you don't have that, you could figure out somebody developing a API or a common platform that allows these different EHRs to talk and make the e-consult a bit more friendly to do. And then machine learning AI, there was a lot of discussion today. That would be a great, either triaging or doing the really complex ones. So there's some opportunity there as well.
Yes, thank you. Sorry.
One more comment was that the interaction doesn't have to be just between the consultant and the consultee. You could imagine that if you had 2 hubs, they can talk to each other, and then you can talk to the UDN or you can talk to the labs, because I think a lot of these consults will be VUSs. So I think those are the stakeholders of this process. Thanks.
Thank you.
Go ahead, Laura.
I really like this concept and moving forward with this. As you were talking about it, it reminded me of the ECHO program, and which is the Extension for Community Healthcare Outcomes that I believe states are supporting to give rural communities kind of healthcare, where at least the way that our state is doing it is they have different types of specialties that the state then pays for to allow the rural healthcare providers to allow consultations. So, and I believe that this was studied by AHRQ. So I hope that the lessons learned there, we could further build upon them.
That's a really good point. And to be honest, I haven't looked that much into the ECHO. So thank you for bringing that up. I will definitely study them a little bit more too.
One question for Related to the licensure, and maybe Renee. So if this is a provider to provider, does licensure still come up?
It really, Renee's exactly right. It depends on the state. It's considered provision of care by some states. So it's just, just depends.
We've also found that it also depends on what type of institution you're at, that because the state universities have sovereign immunity, that they have different rules than if you weren't at a state. So there are going to be a lot of legal issues too, that regulatory issues that whoever applies are going to have to figure out for themselves. The HIV line has been operating nationally, and they don't look into licensure. And it's my understanding that when I talk to them, they have said that the lawyers at their university have said they don't need to. So I'm excited to find out what answers people come up with.
Other questions or comments? If not, can I have a motion to approve the concept? All in favor? Anyone opposed? Anyone wish to abstain? Thank you, Renee.
Thank you.